Hello, and welcome back to the bench. My name's David McCulley. I'm a neonatology physician scientist at UCSD. This is the incubator podcast at the bench, where we are incubating discoveries. We are very fortunate to be able to interview neonatology physician scientists and hear about what inspired their work. And today we have a special guest that I'll let Betsy Crouch introduce.
Hi, everyone. Thanks, David, for passing the baton to me, so to speak, virtually. I'm Betsy Crouch. I'm a neonatologist physician scientist at the University of California, San Francisco. I'm quite thrilled today to interview our guest, Dr. Ben Fensterheim, who is currently instructor at the Children's Hospital of Philadelphia. Ben, we'd love to hear more about you, so if you could take a minute and provide a brief introduction.
Yeah, absolutely. So hey everybody. My name is Ben Fensterheim. I, as Betsy mentioned, currently am just transitioning right now, as this is between June and July, to instructorship from fellowship
Congratulations.
at CHOP. I completed both residency and fellowship at CHOP. I in order to get some time for research, actually during my training, I completed what's colloquially called the fast track through residency and fellowship, which is 2 years. You get to do 2 years of residency instead of 3, and then you do 4 years of fellowship instead of 3, with that extra year in residency for a little bit of extra research time. So I am finishing all that up. Hopefully getting a publication on my fellowship work out soon, and moving on to the next projects and the next things at CHOP right now. Before I was at CHOP, I trained in the MD PhD program at Vanderbilt University. I would say two people that are really important that I could talk about that were at Vanderbilt that really inspired me are my PhD mentor, Ed Sherwood, and also Terry Dermody, who was the MD PhD program director at the time. Both of those folks I can talk about later that really inspired me to continue through this. Prior to that, I was at the University of Michigan and studied neuroscience. And then I guess I'm going back in time, but I grew up in Maryland, outside of Washington, D.C.
To see where you were from. I was guessing New York City because,
No.
University of Michigan is colloquially called SUNY Ann Arbor.
Yeah.
Because there's some New Yorkers
definitely
who
a
go
lot
there.
of people from New York that go there. Yeah.
Yeah.
And DC suburbs, turns out. So, I'm from Maryland in a town called Rockville, which is really cool. Rockville's right next to Bethesda. So, my very first experience in science when I was in 11th grade was a 2-month internship at the NIH in the lab of Bob Cedar, who, after all this time has passed, turns out that he's friends with my current PI, John Larry.
Wow.
And they work on immunology in similar ways. So I somehow made my way back to the very first thing that I did when I was in high school. So
That's a beautiful story. I have things that, I guess, scientific experiences that are not on my resume because they didn't produce any publications. And one of them is that I spent 2 summers at the University of Pittsburgh, which is where Terry Dermody, I think now is the department chair, correct?
yeah, he's the chair of pediatrics.
So he has some fantastic stories about being a Dallas Cowboys fan in Pittsburgh, where, the Steelers are basically a religion. I also have really enjoyed my interactions with him. But my first experience in a lab was with a neuroscientist at Pitt called Crowley Murnix. He's now the chair of neurobiology at the University of Nebraska. And although my work there, actually, I was really inspired by my experiments, but they had negative results. Like they went correctly, but we didn't find what we were looking for. But it was so inspiring to see somebody. He was one of the first people to do microarrays on individuals with schizophrenia. And I think that, habit of thinking about the latest cutting edge science and how we could use it to impact people's lives, is a experience that I had that, still drives me today. It's just like I think those early those early influences can be so trajectory setting for the rest of your life.
That's amazing. I completely agree. When I was in high school, which was when this all sort of started, despite my endless education and academic training, I was not a good student through most of high school. The reason why is that I really just didn't find it important, or I just didn't care about school. I thought that music and sports were more important for most of my upbringing. My homework percentages in each of my classes suffered because of that, and then ultimately my grades suffered. Um, so it was actually around 10th and 11th grade when I started to explore, because I had these kind of few experiences that really inspired me about the power of technology, is what it was. One was I had a great English teacher that taught well, she allowed me to read what I wanted to read, which was very important to me. And when I ended up choosing to read off of her list of books to read was Walden by Thoreau.
Yeah.
And the 10th grader in me that just chose this book to read and watched someone choosing to kind of take ownership over his life in this very unique way really inspired me, that there is so much that you can accomplish if you have a vision for what it might be. Um, and then at the same time, I was exposed to, I think, the development of new, there were a lot of new technologies that were coming out, I guess, around that time. The iPhone was just kind of coming out. People were starting
Cool.
to talk about virtual reality. I think around
The
that time,
Matrix. No, it
I
was a
think,
little.
yeah, yeah. I think I saw The Matrix around that time as well. And I
Yeah.
remember thinking that all of these things were made possible through scientific discovery that ultimately translated into the development of technology. And what an amazing thing to do to create new technologies that directly help people's life through health. That was kind of my original thought. And that process started with me asking around to see if anyone knew anyone in science. And my uncle happened to be friends with someone who was friends with Bob Cedar. And then a few months later, I was doing Western blot in his lab. So that was how it started. And really, it's been that drive to want to use science to make something tangible that helps people that really has pushed me forward. I think there's another phenotype of scientist that wants to discover knowledge um, out of the pure love of discovery. And that's probably actually more important to science than what I want to do. But personally, I was driven by the desire to take knowledge that many other people have discovered already and try and find a way to apply it in a way that's tangible and helpful. Um, yeah.
That's one of the things that I really like about being a physician scientist. I feel like we do form that bridge between that other phenotype of scientist that you described, where they're in it just purely for the sake of trying to figure things out, trying to discover things, make sense of the world around us. And then I think as physician scientists, we're motivated by the patients that we take care of to try to find ways to use scientific discovery to help people or better understand issues in healthcare or issues of um, pathogenic mechanisms of disease and things like that. And so I love this idea of being a bridge between those two worlds, and enabling the utilization of science in a way that's helpful to help somebody with an illness that they might have, or just to live a healthier life. So it's interesting that you also see that as just two separate phenotypes.
Yeah, I actually, I interact now with a lot of the former, the true science phenotype
Hmm.
a lot. And, these individuals are extremely bright,
Hmm.
extremely motivated, and they have more time than I do, because now I have to work in the NICU periodically, and I have other responsibilities. So when I think about um, trying to pursue that in a meaningful way, me personally, I actually think better that they are discovering this foundational knowledge, that's what they're here for, and I really am not in a position to compete with these incredible people. So actually, I feel like it would almost be a waste of my training to spend all my time just trying to discover foundational facts. But my niche is in taking that discovery and translating it into something. And no one is going to fill that gap other than people that understand both the basic science and what's needed for babies.
I'll give a shout out to a friend of mine, Kara Marshall. She's a basic scientist, a PhD at Baylor College of Medicine in Houston. She studies interoception and is brilliant and also a brilliant science communicator. And she recently gave a talk actually to her parents' retirement home about the history of science in America. And she has this like really fun kind of audience quiz that she gives, which is like match the basic science discovery with the like technology that then like led into this like groundbreaking therapy for humans. And it's really fun to hear about how like how CRISPR, like I think we're now very familiar with Jennifer Doudna's like discovery of CRISPR and what she was originally studying in these like esoteric, viruses that infect bacteria. But also like GFP, Ozempic, like Ozempic was, and correct me if I'm wrong, like studying the spit of the Gila monster, something that's like quite, quite like TV show, National Science Foundation, not really NIH type of work that led into these things that really have impacts on human health. So it's quite cool. Thank you, Ben. That was really fun. I think just to, focus you a little bit or transition to the next stage, I guess. So then from your very broad kind of early explorations with education, what led you then down the like more focused path of your MSTP and then into, of course, the best subspecialty in the world, neonatology?
Yeah. Good question.
The best
So yeah, my life. What's your life story? Um,
Yeah, in like 3 minutes or so.
yeah. So
Kidding. You can have 5.
what?
I said, I'm kidding. You can have 5.
Okay, I think I can do it in 5. Um, so when I went to the University of Michigan, after begging them to let me in, after high school, despite the fact that my freshman and sophomore grades were abysmal. But I ended up going to the University of Michigan, and when I started at the University of Michigan, while I was interested in science, what ended up inspiring me at the time was philosophy and the philosophy of science and how science played a role in philosophy of the world today. And I started out as a philosophy major at Michigan. One of the areas in philosophy that was really the most interesting to me was the philosophy of mind, and topics discussion of free will. And as I was studying that, I was like, the conversation is a science conversation, not a philosophy conversation. And so if I want to get, at least how I was thinking, if I want to get real answers to whether we have free will or not, which was what my naive brain was thinking at the time, I need to go into a neuroscience lab and study how we make decisions about what we do. So
I was
it
gonna say,
turns
I
out,
am on the edge of my seat about how this like abstract philosophical stuff is gonna lead into t-tests, but take us on the journey.
yeah, it was really, I was driven by, I wanted to answer this question. And I thought that about what free will was and whether it existed and how it manifested. I actually wrote my thesis in philosophy. I ended up minoring in philosophy and majoring in neuroscience. But I wrote my thesis about this whole theory of how the brain might manifest free will, and how it's all kind of encoded in neurologic structures. And the whole thing is this neurologic experience that is very real. And so we shouldn't be denying its reality because a prior philosophical system that we had doesn't fit with our own theory. Really, we just need to change our theory or our thinking about what free will is, or our definition of what free will is, and then all of a sudden it is true again, even in a deterministic world. So I wanted to study the foundations of those neurologic systems. I joined the lab of amazing neuroscientist named Josh Burke, who's at UCSF, and I did recordings of rat and mouse brains using these electrophysiology apparatuses that we would implant into their brains and listen to them while they made action decisions. Um, it was really fascinating, but when I was wrapping up my time there, I felt like I didn't really know what I had really learned from the experience. I found that yes, there were these neurons that existed in the brain that could control action, but that didn't turn into meaning for me, which is what I was looking for when I originally started in
Ben, can I
yeah.
ask you, so just so I understand it, you were really interested in trying to figure out, like, how in your brain do you take a thought, eh, turn it into a decision, and then how does that get translated into an action? So you were trying to use the electrophysiology in those rat brains to try to study how that process happened. Is that right?
Yeah,
Okay.
exactly. It's exact I mean, the lab was focused on processes that might be relevant for movement disorders,
Got it.
was kind of the health relevance of the lab, but
Okay.
it was very philosophical,
Yeah.
and it was trying to understand the neural circuitry that allowed us to, make decisions. So yeah, that's exactly right. It's fascinating work, but personally, I think because I didn't have that applied use for it, it didn't have meaning
Got
for
it.
me in a broader way. I wasn't sure what to do, and I ended up speaking with a guidance counselor at Michigan when I told her about this, and she asked me, "Well, what do you really want to do with your science?" And I said, "Well, I want to make stuff, and I'm learning a lot, but to me, meaning comes from making things, and science seems." I went back to my kind of my high school self and thought, science should be about making things, at least for me. And what she should have said was, "Oh, great, you should do bioengineering or
Yeah.
biomedical engineering." That's exactly what they do. Instead, what she said was, "Oh, you should do an MD PhD program." Um,
Aren't we
because,
lucky?
That
yeah,
worked out.
because that's what they do. Um, and I kid you not, when I ultimately showed up on day one of the Vanderbilt MD PhD program, I was not completely, but a little bit surprised that I was just in medical school and I wasn't in some translational science um, school for
Mecca
people that wanted to make stuff. Um, yeah,
would have
so
entered these physician scientist promised land,
exactly.
where the patients are on your left side and the experiments are on your right. Anyway,
Yes. It was pure naivety. I just didn't know. And the reason why I went into so much detail about that story is like my time from the beginning of Vanderbilt when I started the MD PhD all the way up until now um, has really been driven by this need to apply science to something meaningful because that's what I was looking for all along was meaning. That was how I got into science was through the meaning that philosophy and science might provide, and I'm still kind of chasing that. Um, so that was really the driver.
That's so inspirational and really great to hear about. I mean, I think one of the reasons that we wanted to have you on was just because you have a great story and also you're right in the thick of this. So it's
yeah.
really interesting to really dig into what inspired you, what motivated you. Can you just talk a little bit more about your decision to apply for an MD PhD program? Like, just hearing that suggestion from that counselor in Michigan, it certainly sounds reasonable to consider. Like, what else went through your head? What else were you thinking about?
When I decided to apply, I was considering applying to either a PhD only program or an MD PhD program. Not, I never considered only applying to medical school. Um, and um, yeah, what was going through my head? I mean, part of me, because I mentioned I'm not the best student, part of me thought I wasn't going to get in. And that it would be the dream if I could go. So I had sort of this like unknown reason for aspiring to something that was prestigious and greater than me. Um, the other reason was I really believed when I was applying to the program that this was going to be the best way to learn what I needed to learn to make concrete um, improvements to health. I can't remember exactly where I got that impression, whether it was just that guidance counselor or whether there was more, but um, I felt like this was the most robust, the most thorough way of getting into a position where you can really make a difference in healthcare. And I think I probably was exposed to examples of folks that had an MD and a PhD um, who were making that difference, and was inspired by them. I probably just wasn't exposed to as many people, let's say in like bioengineering or something like that, but because I was in academics. But yeah, that was kind of my consideration when I applied to Vanderbilt. So I applied broadly. I remember to MD PhD programs, um, and I did not have high hopes for myself. My GPA, I think, was below what people told me I needed. I think it was like a 3.4 or a 3.5, and everyone said you needed a 3.99. And I was like, well, okay, I'm out, but I'm gonna take my shot. But I ended up connecting with people at Vanderbilt. I was just in Nashville on a trip and connected with the folks that were in the MD PhD program there because I asked to set up a meeting. And I got this sense that the Vanderbilt MD PhD program had the same philosophy that I had. And I think they got that sense that I shared their philosophy about training and what they wanted to get out of training. And so it became this like perfect match. It was my first interview. And like by the end of the interview, I was like, I'm going. And I think they even were like, he's going, because 2 weeks later I was accepted and I was the first MD PhD student um, enroll. And then I spent the rest of the time trying to recruit my classmates. Um, so I was very pigeonholed into Vanderbilt, like from the very beginning. Um, I never ended up applying to a PhD program or an MD PhD program. I did interview or a MD only program. I did interview at a couple other places, but yeah, Vanderbilt was my spot.
I
It's
think
really
that's so
helpful to
cool.
hear.
Oh,
Yeah.
go ahead.
I just wanted to say one thing. Just it's helpful to hear when it came to you that this was a good path. That it was a way that you could do something that would be impactful, that would be important and, inspiring for a lifetime. Because we're really trying to figure out like how do we interest people in this pathway generally, physician scientist pathway. Definitely, as Betsy said, neonatology is the best. But just in general, we're worried about this record of physician scientists and trying to figure out where along the path of training and education should we focus on trying to attract people and tell them these motivating stories? And it sounds like it occurred to you, like while you were finishing your time in Michigan as an undergraduate and applying for the next step, that it really kind of solidified. Do you think that's right?
Yeah, definitely. That was where I heard about the MD PhD program. But I really saw the MD PhD program as an outlet for my what I wanted to do with my life, and that was developed even earlier in high school, for me at least. So I might be a unique, like not everyone starts in philosophy and ends up doing this still as a outlet of philosophy, weirdly enough. But that was where it really started for me. Um,
But I do think as we're talking about phenotypes, that this is a phenotype. So I was fortunate to be able to, go to UCSD recently. I gave a talk to both the PhD community with the biomedical sciences graduate program, and then David arranged for me to give a talk to the NICU, or I guess to the NICU and pediatric practitioners, honestly, more broadly. And one of the things I was able to do was go to dinner with David's neighbor, who is Dr. Cole Ferguson, and he's a neuropathologist and a physician scientist. You two are a similar phenotype. This like he's like, I'm really fascinated in the way that like very microscopic things translate into global principles, right? It was like, it's very philosophy driven. And I was fascinated and delighted, and also thought, I will never be in that same headspace with you, because that's just not the way I think about things. I like stories. I put things together into narratives. That's the way I think um, about science and medicine. Is very much like yeah, I'm very narrative driven as opposed to philosophy driven. But
I think as
I love
yeah,
I love that phenotype too.
yeah, I was gonna say, as I've spent time in the NICU, I think become more narrative as well. Um, I think I've been pushed by real events and real things that are happening to real people, and that has real meaning for me now.
Yeah, that's very interesting, because I do think philosophy is so beautiful and so abstract sometimes.
What
Yes,
I liked about it was the way that you can construct an argument. I really took away from my philosophy class just the way that you can come to a conclusion, and that you should think about like every aspect of like what allows you to come to that conclusion with like little hypotheses, construct an argument, see what you can do to support that argument before you can actually make a conclusion. So I saw it as an approach, and that helped me think about like, okay, I can use the same kind of ideas in science where I'm using experiments and data to help support my conclusion.
I absolutely love that we never know where this podcast is going to go.
Yeah,
And
it's
I
really
did not
interesting.
imagine this morning that interviewing an
Philosophy.
immunologist that we were going to talk so long about the philosophy of mind, but I've really enjoyed. I would like to hear some about your current experiments and your current vision of who you are and what you want to do as you launch into an early faculty career. You have some challenges ahead of you in terms of negotiating for that first startup package, but I think it's also a fantastic time to, think about your 5 and 10 year plan, and to imagine how like your future and the future of our babies could be different if like all of your experiments go to plan, or at least half of them.
yeah, yeah. Hopefully, half. Um, Yeah, so I ended up when I was in graduate school, I ended up moving to immunology. And so, like you mentioned, I'm now studying immunology. And the reason why I did that was because I thought that immunology was a better outlet for translation than
Mm.
neuroscience would be.
Yeah.
I was just seeing all these new immunology-based therapies that were coming out at the time, and mostly in cancer, but also in autoimmune disease. And I was like, this is the field. If I want to make stuff, I have to learn about this. So that was why I got into immunology. I became interested in neonatology in medical school because I had experiences in the NICU that were just really profound. I mean, talking about searching for meaning, it was like left and right. There were meaningful experiences that were happening, and I didn't see a single one when I would go to outpatient adult clinic. That felt like going to get your like a car mechanic or something. And then in the NICU, it was like these profound life altering experiences were happening day to day. And I was like, this is where I want to be. This is what I thought medicine was and what I want to do. So it was a combination of a love that just happened for neonatology. It was totally irrespective of my scientific interests. Um, and then once I was in the field and thinking about, well, how I'm trained in immunology, how can I do what I wanted to do originally, which was bring immune therapies to patients? How can I do that in the NICU? Looking around at what we knew about neonatal immune systems, when I started my fellowship, I was shocked at how little we really understood. I mean, I think still people are trying to profile just what is even happening to these cells at various stages in development. And part of it has to do with the fact that historically, we haven't had the technology to profile such small amounts of blood, um, especially repeatedly. And also that things change in the immune system super fast. Like as soon as you're born, within an hours, your immune system's different. So it's a really difficult question to answer. But despite that, I was seeing uh, so many opportunities for immune therapies in the NICU. Every condition that I seem to be caring for, BPD, PDAs, even necrotizing enterocolitis, sepsis. They all had these core immune links that were driving the pathology. It seemed so apparent that there was a need for immune therapies in the NICU. Yet the only one that really existed, it still exists, is dexamethasone. I think of that as the only real immune therapy, and we use it for literally everything. If anything's going wrong, we just give dexamethasone, like really wrong.
Yeah, Ben
And
and
it
Daphne
seems to help,
talked about this
you
recently.
know?
Yeah,
What?
Ben and Daphne talked about this recently, like our
Oh, yeah.
ancient tools that we're still using in neonatology, despite our ancient medicine, despite our like absolutely cutting edge technology. It's a
Mhm.
really
Yeah,
it's a curious contrast.
exactly. And um, we have the technology, like it exists. There are antibodies that could help infants that are currently being given to adults. There are um, gene therapies that are being developed. There are CAR T cells that are being developed. There are so many new technologies that are coming out and that have come out even over the last 20 years. But when I think of, at least for preterm infants, um, in the last 20 years, of all these new therapies that are coming out, how many new therapies actually made it to the NICU? It's not many, almost none. The last major that I consider the last major breakthrough in neonatology that was truly brought to the NICU was really like therapeutic hypothermia. Caffeine was done before that, nitric oxide was done before that, all these foundational therapies were done before that. And since then, there have been a lot of optimization and improvements in the way in which we administer care. But in terms of brand new, now we can give you this medicine, we didn't have it before, here you go, therapies, there aren't many at all. And so if you're asking about what my real goal is now, and in the next 5 to 10 years, it's to start on that path to bring a new therapy to the NICU.
Which
And
one?
that, all right. So I can talk a little bit about my science.
Yeah, I mean,
So
and please don't tell us anything that's like protected. So
no, none of this is protected. This is
Mhm.
all conjecture. And I'm going to publish some of my stuff soon. But my study and fellowship was about understanding how the immune system evolves during the first 2 to 4 months of life while preterm infants are in the NICU. And the reason why I wanted to look at that is because I wanted to understand what was happening to the immune system as infants ultimately went and got things like chronic lung disease or developed infections or whatever. And I wanted to take a whole picture of the NICU, whole picture of the immune system, and then keep checking and checking. And then as clinical situations evolve, all of a sudden, what can I see change in the immune system? So there were kind of two things that really popped out of my data that I am excited about following up on. One is I found that infants with chronic lung disease, and the reason why I could look at chronic lung disease is because most extremely preterm infants develop chronic lung disease. I just simply didn't have the power to look at things like NEC or IVH. But so for the infants that developed severe chronic lung disease, meaning they were on a ventilator at 36 weeks, corrected gestational age, and compared to infants that were born at the same gestational age who just had grade 2 or moderate BPD, who are just on non-invasive support at the same time, the infants with severe disease had a way overactive T cell system called the Th17 system, which is just a bias. It's a bias in T cells to make a certain type of pro-inflammatory mediators, increasing neutrophils in the blood, sending neutrophils to sites of mucosal inflammation like the lung. I mean, it makes biologic sense the system might be activated in chronic lung disease. And it was almost like a split in ventilator settings. The infants with severe BPD just kept going way off into this direction, and the infants with moderate BPD who were born at the same gestational age went off into a different direction. There were some aspects of this bias to make these Th17-like molecules that was present even at birth. It almost like these babies were born wired to be polarized into this way. And I think it's reasonable to ask whether this system is driving inflammation in chronic lung disease. There are mouse models that have blocked the cytokines that are involved in this system in mouse models of BPD, which are not perfect human models, but in mouse models, it seems to really relieve a lot of the inflammation and distortion of lung architecture that happens in mouse models of BPD. And this is targeted, molecules in this pathway, cytokines, are targeted by FDA-approved therapies that are being given to individuals with autoimmune conditions like psoriasis. So these things exist. They might, I don't know if it's going to work, but it potentially provides at least an option to explore as an alternative anti-inflammatory therapy that would be way more targeted than giving something like dexamethasone.
Okay, I have an immunologically naive, haha, get it, question? Uh, I think of Th17 as the tolerance mechanism. Is that an incorrect assumption, or like
It is incorrect.
At least correct? Okay. I mean, I guess, like, in terms of, can you provide a little bit of basic, because I also know that there are differences in terms of the way that the certainly prenatal and neonatal immune system is poised compared to the adult immune system. So it's
Yes.
possible that I'm just wildly incorrect. I think it's also possible that there are differences between like the adult immune system and the neonatal immune system in terms of the subset and the roles of Th17 specifically.
Yeah. So I can explain a little bit about the biology. So the Th17 system is a mucosally focused system. So it does play somewhat of a role in balancing the interface of microbes into places like the gut. However, the main cytokines and molecules that Th17 polarized CD4 T cells, which are the CD4 T cells, just the phenotype of cell that gets polarized in this way. The main molecules that they make increase neutrophil production from the bone marrow, and they activate epithelial cells at sites of inflammation, mucosal inflammation, in order for tell those cells to make neutrophil recruiting cytokines, and ultimately drive inflammation in outwardly patient or environmentally focused sites. It's the oldest, actually, TH system. It evolutionarily came before TH1 or TH2, the two other systems we think about. And its tie-in with neutrophils, I think, reflects that. It was originally explored as a driver, and it is a driver of inflammation in inflammatory bowel disease, in psoriasis, and a number of other autoimmune conditions, which is why there are so many blocking agents for the molecules in the pathway. This is in big contrast to some of the other TH systems. So in infants, a system that's thought to be more anti-inflammatory, or at least not as inflammatory as Th17 or Th1, would be the Th2 system. It's thought that infants, when they're born, are a little bit Th2 biased. It's also thought that they have more cells. They're called T regulatory cells, or cells that are explicitly designed to suppress inflammation, secreting molecules that suppress inflammation. So infants that are born at term in normal situations have been found to generally be Th2 biased and have more T regulatory cells than an adult would. The process, I guess I'm going to be going on too long if I get into Th1 too, but
No, it's very
Th1,
helpful. And I got to interview Amelie Collins earlier this week, actually, with Misty Good. And she is focused on the hematopoietic stem cells as the foundation of the immune system. But it was great because it's like all coming together, because I think those, like, I'm going to say an immunologically naive thing. IL-10 is a Th2 cytokine. Yes, it's
an anti-inflammatory cytokine. Yeah, it can be made by Th2 cells, or the T regulatory cells actually make a lot of IL-10. Yeah.
Yeah, but what she found was that, at birth, that moms make a lot of IL-10, and this is one of the reasons that HSPCs can't make enough neutrophils, to combat sepsis in our even full-term babies. So fun. We're like really putting together different themes in immunology here at the bench.
I think the point of all this is that the infant immune system, and even more so the preterm infant immune system, is way different than in the adult immune system. It's wired completely differently because of what's happening. And it's changing super fast. So if you look at an adult um, on January 1st, and then you come back and look at them 1 year later on January 1st, their immune system is going to look essentially the same unless they've experienced some brand new disease. But an infant's immune system will be genuinely unrecognizable in that same time frame. There's good publications showing that things change within hours after birth. And so it's a moving target. And I think that also complicates things. It makes it really interesting.
It's so funny just because you think like I can understand the rationale for in an adult where immune system is sort of a little bit more like established and you have a disease that you can target really specifically. It seems like you should be able to translate that therapy just as you are indicating or sort of alluding to an infant. But as you've pointed out, like the immune system in those preterm infants is changing very quickly. And in addition to dealing with whatever pathology is going on, it's also required for normal development. So I can understand people's hesitation thinking like, well, we don't want to go after that specific thing because God knows what else it's doing. It might be really important for this other thing that we don't even know anything about. But despite that, we still are willing just to put on dexamethasone, which does a
Yeah.
gazillion different things. Also, we don't really understand all that well, but we're like, well, things are bad, so we're going to treat with dexamethasone now. So it's just interesting that that's the approach that we've taken.
Yeah, I mean, I agree. I mean, no therapy is going to be without a side effect. And uh, I think every decision is a calculus between two different outcomes, not necessarily one with disease and one without. And, chronic lung disease, just the disease itself, has a whole range of really unfortunate outcomes that are associated with it. Neurologic outcomes, lung changes, growth. I mean, it's not a good disease. Especially severe BPD is you don't want it. You can die from severe BPD. So um, that's what we're weighing against. So if a molecule does change a little bit of development, it's important to know. And then the question is that change too severe, too bad compared to the thing that you're trying to treat? I think it's interesting to think about dexamethasone because the pendulum has swung a lot on steroids, and I think we were using them all the time, from my understanding, as someone who was in the field. We were using them constantly, and then when everyone found out that they potentially could increase cerebral palsy risk, we stopped using them completely. And now my sense is that the pendulum is really swinging back into, well, let's use them in a really kind of thoughtful way where we're not just putting all babies on it right at birth, but using
But
it in
when
short courses. Yeah. And I think that's a nice example of this calculus, because what people end up realizing is when you didn't have dexamethasone, you ended up with these kids with chronic lung disease who were just really sick and had cerebral palsy. I mean, it didn't really change that outcome. So it's a hard decision to make. I actually would argue that I think we should be more open to new technologies that might have side effects, but study them in a way that is really careful, because the outcomes that we're talking about are really unfortunate. I think it begs for something new, and to try something new, and to then understand what's going on. I think a great example of this happening just was published recently at CHOP that you guys might have known about. One of the first uses of CRISPR gene therapy for a child with a metabolic condition in the liver, which is what these nanoparticles with the gene therapy really do well at treating. But they went through a approval process that was very quick, because this child was going to die from the condition if they didn't get therapy. There were unknowns about its safety, but because the outcome that they were trying to fight against was so terrible, it was death, they were able to get things through, and it really helped the child. I think there are parallels in neonatology that we could be really helping people by bringing and trying new therapies. And wish and hope that people will be open to studying these new therapies more in the future.
Yeah, thank you for bringing up
So well said.
that amazing story. I agree. That was a good day when like that came out.
Yeah.
I think it demonstrated how cutting edge science changes lives, like gave a child a future who didn't previously have a future.
Yeah.
Other thing about that story is how much they worked with that family, right? This was absolutely science and the community working together, and that's also how we need to move forward. So thank you.
Totally agree.
One of the other reasons, in addition to what's been just a wonderful story to talk about, getting to this place in your scientific journey, the other reason why we wanted to bring you on was to talk a little bit about your new position in the AAP. So I'll give a little bit of background that I previously was the research chair at TCAN, which is the Trainee and Early Career Neonatologist, and I was delighted when I was able to pass that off to Ben. So Ben, do you want to talk a little bit about what led you to apply for the position and what you're hoping to accomplish in that role?
Yeah, absolutely. Thank you for your trust in me in doing this um, role. I'm really excited to be involved in TCAN, especially in this position as the research chair. Um, the reason why I really wanted to get involved is I was feeling the pressure and seeing the pressure being applied to other physician scientists or physician scientist wannabes in neonatology around me, and um, was watching a real interest from many people get kind of squashed by the current environment for our career development and the broader funding environment in the United States. There's so much pressure right now, and so little support for people that are interested in pursuing a path in research in neonatology. So I really wanted to support this community, and I wanted to do it in kind of two ways. One, I think one of the reasons why there is a lack of support is there's not great community amongst the physician scientists that are in training, or the neonatologists that are in training, or the ones that are in the early career and just getting out. I've felt, and I know other people can feel very alone doing the work that they're doing. Um, I work in a lab that is really doing cutting edge immunology. The people are making the next cancer therapies and so on. And I'm in the corner kind of studying preterm infants, and I'm doing my own thing, and I'm kind of alone. But
That's an opportunity also, but
it's an
yeah.
opportunity. Yes. I'm taking the opportunity. But the sense I felt alone, I know other people feel alone, but we're not alone. There are many people around the country that are doing this. We are just diffuse. We just all aren't in the same location. And so one of my main goals as the TCAN research chair is going to be to connect physician scientists around the country in order to provide them support to get them through tough times in their career, including myself. I consider myself someone who needs the support. So that's one. The other thing is, I think we can continue to do a really great job of advocating for the value of science in neonatology. The entire field of neonatology exists because of science, and because of translation of science into real therapies. The story of neonatology is fascinating. It's a story of science, and I think simply our existence advocates for the value that science can bring. And especially now when there's so much confusion about what science is, and so much misunderstanding going around, I think we are in a great position as physicians who are taking care of infants who live the benefit of science. We're in the best position to share all of the amazing work that has been done to get us to this point. So I would also like to speak to the public and communicate with the public more, to start a dialogue and share more and hear more about science and about science in neonatology.
Yeah, we're really excited to, partner with you. I'll give a little teaser that we're going to be doing some at the bench science inspo sessions, and so look forward to seeing those come out. And I think for our listeners, if you have ideas about what specific topics would be helpful, I was thinking that from your earlier biography that talking about fast tracking would be helpful, probably for folks who are coming up in the physician scientist training path, but also I think topics that are more useful to folks who aren't neonatologists, physician scientists, and thinking about, how our benchtop experiments can lead to impact for babies is probably very important. Well, David, do you want to wrap us up and ask Ben about some of his
Yes, I can do that.
super interesting hobbies that I'm excited to
Yeah.
hear about?
Ben, that was amazing, and I'm so glad you seem like a perfect spokesperson. So I'm really excited to see what you do. But one of the other things that we like to close with in the podcast is just sort of demonstrating our humanity. And it sounds like you have some interesting hobbies. So I don't know, could you pick one or just something that you'd like to do outside of your work in the NICU and in lab that just is just interesting that you think the audience would like to hear about?
Yeah. Pick one. Okay, so currently, my current obsession right now, but this has come and gone, has been with the Japanese maple tree.
Mm.
Acer palmatum is the name. I have become totally fascinated with these trees, and have been studying them in my spare time. Um, they are, if you haven't gotten into Japanese maples, give them a chance because they are the most diverse, beautiful, psychedelic, um, resilient trees that exist. And there is so much to get into. So I've been growing Japanese maples at my house, which I only have so much limited space in Philadelphia,
Yeah, it's a commitment.
um, but I'm really getting deep into the history and the biology even of Japanese maples. So
That's
that's
perfect.
my current hobby, coming off of the heels of my prior obsession, which was birding. But we'll have to uh, have an interview separately for that.
That's
And you
perfect.
said previously you were really into being an amateur radio host. So there's
Oh yeah, before the birding, it was music. I mean, music has been a huge part of my life. I was a radio host for 4 years, playing music. I've been in bands throughout my life. Probably been in about 4 or 5 different bands. None currently because of training, but um, yeah, I play every instrument that's in a rock band, and I will attempt to sing poorly, but I'll attempt it, which is all that counts. And yeah, so many changing interests. I mean, uh, I think being fascinated with something is so important, even if it's a tree or a bird.
I think
yeah.
you're absolutely right. That's an important part of this phenotype is just a willingness to explore, like have an interest and find time to explore it. I think that's a really important thing. And it's great because, you get to find out something interesting or do something new and share it with other people. But sometimes it's just, interesting for yourself. Well, thank you so much, Ben. It was fantastic to talk with you. Betsy, thanks for co-hosting with me. Thanks to our audience again. It's such a great opportunity to be able to talk with neonatology physician scientists. So, looking forward to talking with you again soon. And thank you all so much for tuning in. Have a good day.